your 1 hour fun day?
Oh yeah, this is extremely fun. Don't worry about that.
Sorry about that. I kicked myself out accidentally. My bad. Anyone interested in thinking out loud with me for Mario's case? Reshma, awesome. Am I pronouncing your name right?
Yeah, you are.
Great. Tell us about yourself, Reshma.
I'm Reshma. I just graduated med school 6 months back. I'm from India. I am currently doing research in California at Palo Alto. I gave my step 1, step 2 last year. I am applying for my internal medicine residency match this year.
Awesome. Fantastic. Great to see you. Thanks for being here.
Thank you. Thank you so much for having me with you.
Anyone interested in joining? I know, Maddie, you said you'd be happy to. That would be great.
Yeah, but if you want to co-discuss with Reshma, that's better. I've had plenty of opportunities, so definitely Reshma's awesome.
We can definitely do a more the merrier too. Yeah, why don't we tag team it together, the three of us, and we'll have Mario start, but maybe Reshma, when we get the first bit of information, you can kind of just share your initial thoughts, and then we'll sort of alternate and go through. But Mario, excited to hear what you've got for us.
Yeah, perfect. So this is a case of a 83-year-old female patient that came with a history of 3 days of intermittent chest pain.
Awesome.
Cool. So shall I go ahead? Okay, great. So when I think about so this is a very good initial presentation of the case. We have an 83-year-old female, so which is an elderly female, and presenting with a 3-day history of intermittent chest pain. So the chest pain is typical for like non-anginal chest pain because it is, it's a female, but again, it's 83 years old, which is like making us think towards anginal type of chest pain. And also, so because it's a female, we can think that the age factor brings down the estrogen effect on the heart. So we can also think of, the main thing would be anginal chest pain. And we can also think of other types of chest pain like costochondritis or any lung disease causing chest pain too. Do you have anything to say?
Maddie, want to add anything in before I jump in?
Yeah, definitely. And apologies if it's loud. I will be inside soon. But I think Reshma hit on a really good point that with chest pain, you can think of both morbid and benign causes. I think in an 83-year-old with, I believe I heard 3 days, so this is pretty acute chest pain. I think the first things going through my mind are that I don't want to miss these kind of highly morbid, as they call it, do not miss causes. And CP Solvers has this kind of 4 + 2 + 2 schema with the 4 cardiac, the 2 pulmonary, and the 2 esophageal causes, kind of like do not miss causes of chest pain. So, we can definitely go through those. So like the 4 cardiac, that's like the 2 A's and the 2 T's. So the 2 A's are acute coronary syndrome, aortic dissection. The 2 T's are tamponade and Takotsubo's. And then the pulmonary or pulmonary embolism and pneumothorax, I believe. And then the GI ones are esophageal impaction and rupture. So those are the ones that I'm like, do not want to miss. And so I think for workup, we'd want to get like a chest x-ray, an EKG, but really kind of ask in the history, like, is there any shortness of breath, any like shortness of breath when lying down, to try to figure out if we like really need to be worried about some of the morbid causes, in addition to some of the less worrisome ones like costochondritis that Reshma mentioned. So those are some of my thoughts.
Beautiful. I think you guys have already kind of brought up such key considerations. I mean, Reshma just mentioning her age and gender as important factors, some protective effect being woman, but at 83, right, depending on what comorbidities Mario tells us about, could be at relatively high risk for acute coronary syndrome, specifically, depending on the backstory, even while being a woman. And then, yeah, very, very great framework for some of the key causes that we really don't want to miss. The only thing I'll add is a quick comment about, one of the common dangerous causes of chest pain we really think about early in everyone coming in is, of course, acute coronary syndrome. And getting additional history details, such as what relieves it, nitroglycerin or not, is it reproducible with pain or not, are sometimes things that we use very highly in our assessment of pain. But I will say generally those history questions don't have as high of a predictive value for acute coronary syndrome specifically as we would like them to. So specifically when it comes to like knowing how valuable additional questions that Mario will hopefully give us an answer to are, there's a really, really great article in the JAMA Rational Clinical Exam series on chest pain, and specifically what history questions help favor specifically acute coronary syndrome versus other. Someone can look it up and maybe put it in the chat, but long story short is very few questions have a really high likelihood ratio, for example, of over 2, and very few questions have a really good negative predictive value. So while getting a detailed history is really going to be critical, and we already have the acute time course of it, we're really going to need more diagnostic data. For example, the test that Maddie brought forward to really push us in the direction of, is this cardiac? If so, is it ACS or is it another organ system? So not to minimize the value of history at all, but we have to be careful of over-relying on certain questions when specifically evaluating for ischemia or not, and putting it in the context of the host and the objective data that we'll get. So Mario, without further ado, maybe you can give us a little more story and we can see what direction to take our evaluation in.
Yes, of course. Great discussion. So as I mentioned, 3 days before admission, the patient referred she was lying in bed at night and that suddenly she presented oppressive thoracic or chest pain with a 7 out of 10 in intensity. It was radiated to the upper left extremity, and it was associated with some paresthesias and some cold sensation on the same upper extremity. The pain lasted for around 5 minutes, and it resolved completely by itself. She didn't have any complaints the next day, but 2 days late. But on the day of admission, so 2 days later, she again presented the pain of the same characteristics. Also she wasn't performing any type of exertion. She was just laying down, and she had the same pain, and therefore that's why she came to the emergency department. In terms of past medical history, she did have arterial hypertension, open angle glaucoma, GERD, and diverticulosis. And yeah, she was on losartan for her hypertension, on omeprazole, but besides that, no other meds, no known allergies, and no known social history or family history for the matter.
Great. Thanks, Mario. Maddie, do you want to kick things off with additional thoughts so far?
Yeah, definitely. So Mario, thank you so much for presenting this case. I feel like this is, in the moment, I'm sorry, I lost the Zoom. In the moment, I feel like we would want to be acting quickly, but it's nice where we can have the time to kind of reflect on this like with a little bit more calmness now. But I think, we talked about in the last aliquot that we really want to kind of rule out the highly morbid causes here. And I think this is making me concerned for an ACS picture. Like this presentation could be consistent with ACS. So I think practically I would be just really interested in getting a troponin, getting an EKG and making sure there's not acute coronary syndrome. I think that's just like, that's a red flag. That is something I really don't want to miss here. So I think I would, before too much of like a diagnostic thought process of the different things it could be, I'd be pretty focused on management and just getting the troponin, D-dimer, EKG, chest X-ray. That's kind of where my mind is at with that information. But I'm curious, Reshma, what you're thinking.
Yeah, so I have a couple points to share. So basically, I present with anything, and she got the pain when she was lying down, and the radiation of the pain to the left arm and causing like tingling sensation is typical of, again, ACS. And given her age, ACS could be the one most important thing that we want to rule out. But also, I have a new thought in my head that because of her old age, it could be something related to musculoskeletal osteoporosis, and she's a female. It could be something related to osteoporosis of her rib cage, given that she had pain when she was not like exerting, and also the pain was intermittent. It went off like completely, and then like it's showing up again, and that's again without any exertion. So musculoskeletal is definitely on my mind, and I of course would first go with ruling out ACS and getting her TROPs and EKGs. And one other thing that we know that she is a known patient having GERD, and that's one of the things that we should consider. But again, I've never seen GERD causing like intermittent pain, but that should definitely be on our plate. Do you want to add anything else?
Really fantastic discussion. What you're both getting at is we're worried, right? Hearing about this pretty severe pain in intensity with some radiation. I did see that Yusuf pulled out of the article that I mentioned, radiation to both arms actually is the best test characteristic of history favoring ACS, but in this older woman with hypertension as a cardiovascular risk factor, totally with you guys that acute coronary syndrome is a particular concern. Particularly, right, given this presentation of an unstable angina, right, without any exertion, having this profound pain, particularly worrisome about unstable plaque, or I saw someone mention in the chat, vasospastic process is a really good thought also. Reshma, I think the fact that you're thinking about the complete resolution of the pain and then its return as a helpful piece of diagnostic data, and I agree, because some of those very worrisome diagnoses on the 4-2-2 differential diagnosis really shouldn't go away on their own, right? Aortic dissection pain shouldn't resolve completely for 2 days and then come back. Pneumothorax, same, and some of those both esophageal pathologies. So I think the fact that from the very front, Mario used the word intermittent chest pain, perhaps will be a helpful clue to one of those diagnoses that presents more episodically to be more likely. But Mario, let's take some more info from you.
Yeah, great discussion. Someone mentioned in the chat some pertinent negatives. I forgot to mention them. So she didn't report any dyspnea, palpitations, sweating, syncope, or dizziness during these episodes or in between them. So yeah, that's a good point. Thanks for pointing it out. So on physical exam, she had a blood pressure of 130/80 with no major difference between both arms. A heart rate of 75 beats per minute, respiratory rate of 16, and she was satting 98% on room air. She had a general, a good general appearance. She didn't have a very toxic appearance. So on the skin exam, she had a capillary refill time of less than 2 seconds, no cyanosis or rashes or skin lesions. She had a symmetric amplexation of both lung fields. Breath sounds were symmetrical, and you could hear them good in both hemithoraxes, and there were no added sounds on chest auscultation. heart on cardiovascular exam, heart sampler, regular, rhythmic, no added sounds, no murmurs or gallops. Abdomen was bland, non-tender, non-distended, and she was oriented ×3, no focal neurological signs. So I'm gonna mention some initial labs. Leukocytes 5,300, hemoglobin 13.2, platelets were 216,000, so all were normal. Creatinine was 0.6, so 0.6, and we got some cardiac enzymes. Troponin T was 0.003, so that's normal. CK-MB was 3.19, which was slightly elevated, and D-dimer was 1.23, was also slightly elevated. So those were the initial labs. We got a chest X-ray, was normal, no perfusions, no major lesions were noted. And just to finish this aliquot, we got an EKG, which noted left bundle branch block, sinus rhythm, and no ST or T changes compatible with ischemia.
Awesome. Thanks, Mario. A lot more great information there. Kudos on, let me just say, very hypothesis-driven physical exam, having thought to check of blood pressures in both arms, symmetric breath sounds, sort of addressing some of those serious cardiopulmonary conditions that we talked about in Aliquot 1 with the physical exam. Really well done. Reshma, what are you thinking?
Yeah, so this is interesting. I was thinking if it's a new onset LVB, just like somebody mentioned in the chat, it should be acute coronary syndrome. But given her hypertension, I believe I have read that even like chronic hypertension with high left ventricular hypertrophy could cause left bundle branch block. But the mild elevation in D-dimer, I'm not sure if we could think of pulmonary embolism or anything, but her otherwise normal heart rate and sinus rhythm and everything points towards like points towards the pulmonary embolism not being significant. But like I think we should probably I think we should probably like get a CT pulmonary angiogram. I'm not sure. I'm not sure. I still think of ACS though.
Other thoughts you want to add on, Maddie?
Yeah, this is super interesting. I think, we had spent the last 2 Aliquots being like, oh my gosh, we really can't miss all these really bad things. And, from the vitals and the physical exam, as Mario was describing this, I became more and more like relieved a little bit. Like this patient, maybe that's a false sense of relief. But, from the vitals, the patient seems relatively stable, like good blood pressure, saturating well on room air, no obvious abnormalities on physical exam. So I was kind of felt reassured as Mario was presenting the physical exam, and same with the troponin not being elevated, the EKG, yes, the left bundle branch block, but I was somewhat reassured to not see the ST segment changes. Similar to like the tension that Reshma was describing, I see the elevated D-dimer, so my mind went to, oh gosh, should we be concerned about a pulmonary embolism here? The rest of the labs in the exam are reassuring, but the pulmonary embolism is just something that I don't want to miss. And I think from the various VMRs and cases I've listened to, I just know that PEs can be very sneaky. So I think I guess I would make sure I kind of rule out a PE by maybe getting a CT PE in that case, while also considering some of the more like benign causes of chest pain. I think, Reshma, you also mentioned this in the last Aliquot, that from the history, the fact that this, like the pain kind of completely went completely resolved and then came back, like using that as a clue. You know, people talked about, could this be like a spasm or something from like the history of GERD and esophageal spasm? Maybe that's something that could explain like the completely resolving symptoms and then coming back. So I had this tension between, I really don't want to miss a PE with that elevated D dimer, but the rest of the kind of data is more reassuring. And then kind of how to, the fact that this is like intermittent chest pain that comes on and off, like if that could be a clue to the final diagnosis, like a spasm or something. And then I didn't exactly know about the left bundle branch block. Could that just be from the hypertension? I'm not exactly sure about that, but that would be something I would be asking people about.
For sure. Yeah, I think you guys are bringing up fantastic points. Two things to add on to. One, just a brief discussion on how much do the vital signs help us with our worry about pulmonary embolism, right? It's on our list. We have this high D dimer pain syndrome that could be compatible. Maybe we could say it's intermittent because she's had a couple PEs that have been embolized from a DVT, for example. Tachypnea is actually the most sensitive vital sign for PE. It's got about 65% sensitivity, whereas hypoxemia and tachycardia are much less sensitive, around 30%. And this is based on those big old PE PIOPED population studies. So the most reassuring factor of her vital signs against PE for now is actually, I think Mario told us the respiratory rate is 16. That's actually the most reassuring piece. Now, does it lower her pretest probability enough for us not to get a CTPE with the high D dimer and an episodic pain syndrome? Probably not, but want to emphasize that tachypnea is our best vital sign for PE assessment. Regarding the left bundle branch block, yeah, I think super helpful to know. Mario mentioned in the chat it was old, but an important way to think about bundle branch block, left bundle branch block specifically, is it's either structural or functional. Functional just means rate related, meaning the RR interval is getting so short with a faster rate that the left bundle doesn't have time to fully repolarize. And with faster rates, you get a bundle branch block. But as you guys nicely discussed, it can be from structural heart disease, and that can be chronic or acute. So yes, longstanding hypertension, Reshma, you're totally right. Absolutely could cause to that. If she had myocardial fibrosis for any reason other than the hypertension, such as prior unknown CAD or cardiomyopathy, that could do it. But that history question that someone asked in the chat is the left bundle branch new or not, is critical, because acute things can cause structural heart disease that manifests that way. We talked about acute coronary syndrome, but myocarditis could acutely present with a left bundle, not in this scenario, but anyone with endocarditis and an abscess actually in the conduction system could acutely develop the left bundle. So in that structural category, super important to know if it's there or not, because the list of chronic versus acute causes can be a little bit different. So I guess what have we decided on for our next diagnostics? I'd also be interested in a PECT, right? We've said not all the features fit well, but I'm with you guys. I saw some discussion in the chat about kind of, are we worried? Do we do anything else for the esophagus pathology right now? What do you guys think? Do we triage and do one thing first, or do we start looking into other causes at this time?
I think we can do one by one so that we can solve it. Yeah, it's in a more systematic way.
Totally, right? If we find the diagnosis with a CAT scan, we're not going to probably pursue that other etiologic category well. And then Ashutosh is saying in the chat, we're going to repeat a troponin in the ECG. Thank you for emphasizing that, right? Mario, remind us how soon after the second pain episode is she coming in? Is it pretty acutely after its onset?
Yes, it's pretty acutely, but the duration was the same as the first one. So I can go maybe into the second allogat because so the patient, as we mentioned, had this brief episodes of very intense chest pain, but in both occasions they resolved spontaneously. So when she was admitted, because of the lab findings, troponins were trended, and she was started on therapeutic dose of low molecular weight heparin, in thinking on possible pulmonary embolism. CTPE was performed, which was negative, and because of the patient was 83 years old, wasn't that fit for a stress test. Myocardial perfusion scan was performed, which detected a defect of perfusion a reversible perfusion defect on the inferior wall of the left ventricle with a 7% extension of the ventricular musculature. Marino, don't worry, I'm gonna type it so you can paste it there. So yeah, at this point, she was scheduled for to go to a cath lab. An angioplasty was performed. She had a stent. She had a stent on her right coronary artery, and she didn't have any complications from this procedure. She had a good hospital course, and she was discharged. But yeah, the case doesn't end there. A week later, she presented again to the ED with the exact same complaints. I can stop there, and we can go into the second hospitalization maybe later.
So she comes in with the pain syndrome again after having had a stent in what they thought was the culprit lesion for that 7% ischemia area.
Yes, that's correct.
Great. Huh. Okay.
Interesting. So basically there are I think there are two ways to look at it. The first one would be there's something else other than the heart that's causing the pain, which could be like we discussed, it could be either the GI, esophagus causing the pain, or it could be musculoskeletal, or even though she had a negative scan for like pulmonary embolism, there could be other causes of the respiratory disease causing the pain too. There's another way to think of it, which could be which would be that a possible complication of the CAT was causing the chest pain, or the possible complication of an angina was causing the chest pain. I think we want to know if the pain was like just again like intermittent, and or like was it what were the vital signs when the patient presented for the next time? That I think that would give us a better idea to differentiate between these two categories.
Yeah, Reshma, I really love how you framed that. You were kind of like, is this new presentation a result of something that, like an intervention or a treatment that we just did, or do we have to go back and kind of question how we were thinking of these initial intermittent chest pains? And I know Noah kind of framed it like that in the chat. I really like your thinking on that. Yeah, this is tricky because I think as you were saying, I would try to I would focus a little bit more on the history and figure out, is this like very similar to the same chest pain episodes you were having, the prior admission, or does this feel like something different, just to try to understand if like, we could also like think of the 4+2+2 again for this nuance at chest pain, because like we don't want to miss those also. But just to summarize, I really like your thinking of, is this related to something we did most recently, or do we need to question the whole diagnosis entirely? And I think right now I would just be focusing a little bit on clarifying the history and the similarities and differences between the chest pain she was feeling prior. But this is very interesting. I'm curious to see where this goes, Mario.
Yeah, very interesting. So yeah, kudos to Noah in the chat for framing it perfectly. Is this a complication of the procedure she just got, or were we really not on the right track in the first place with that, area of malperfusion actually not indicating in the setting in retrospect, right, of the negative troponin trend, an actual cause of the initial chest pain? I've saw several people bringing up in the chat just the paresthesia's quality in the left arm with the initial chest pain, and what the significance of that might be. And I'm just seeing some great thoughts about I mean, Reshma, early on, you mentioned musculoskeletal, but really thinking of neurologic, right? Is there actually sort of neurologic compression causing both pain and paresthesias in the chest and arm with the radiculopathy? And then I even heard someone mention thoracic outlet syndrome, which is essentially compression of the neurovascular bundle between the clavicle and the first rib, very dependent with arm movement. So I love that part of our diagnostic test taking here is going to be iterative history taking, right? We know she's not exerting herself when she's having this pain, but what is she doing physically, right? Is it always with her arm up? Is it always in a certain position? Because that might make us want to open up that sort of muscular neurologic category of conditions also. So what did you do? Oh yeah, go ahead, Reshma.
Yeah. Oh, there's one point that I just thought I would add. Because you mentioned the neurological symptoms, I was just thinking about her age and connecting it with osteoporosis and how it could narrow down the channels, narrow down the nerve exit points, and that could like lead to a possible compression too. I just wanted to add that point.
Love it. Yeah, absolutely. So we see her again. What do we do? Do we repeat some of the same evaluation again? If a stent complication is on the list, what do we definitely need to check again?
I think when we see her again, it's important to evaluate her, like giving the most importance to the history, just like we did the previous time, not rely on our previous history alone. When we elicit history for the second time, it's important to go right from the beginning to take care of all the details. And also, I think vitals first more than anything else. Yeah, so just making sure that we stick on to the details, even if we do it for the second time. I think that's the most important part.
Fantastic. Mario, what do you got for us?
Yeah, that's great discussion. So yeah, at this point, we were also very confused. The first thing that was performed, well, the vitals were, she was stable, normal vitals, the same as on the first admission. So the first thing was to rule out a stent complication. So a coronary CT was performed, and there was no stent complications noted on the CT. She was admitted for further workup, and during another week-long hospitalization, she had 2 to 3 episodes of chest pain per day, and she was put on PRN nitrates, and it was noted that the pain would cede fairly quickly with nitrates, which wasn't tried before. So at this point, a different diagnostic test was performed, and a diagnosis was made. So in terms of the pain characteristics, the patient was again, a history was performed again, and there was no other associations with it was postprandial or fasting, no other association of the pain, just this spontaneous episodic chest pain that would last between 5 to 10 minutes. That in this hospitalization was noted that they would resolve with nitrates. So yeah. I think of it as a step question, and prinzmetal angina comes to my mind more than anything else. Yeah, so I think the spontaneous pain does not showing up on an echo or a perfusion scan, and just resolving with nitrates could point us towards angina that's typical for females, which is called like prinzmetal angina. And yeah, it's really interesting that everything else is stable, and even after stenting, it's just coming on and off. So I think I would definitely have prinzmetal angina on the top of my plate.
Yeah, Reshma, I'm totally right there with you. And I think Robbie put a great question in the chat, like, were there any EKGs during an active episode of pain? I think just as a reminder that like when we are getting these EKGs and other tests, that's just kind of a snapshot in that moment. And so it would be interesting to see if an EKG was obtained during those episodes. And I think reflecting back, if it does end up being vasospastic angina, I think like the point of the history, Reshma, that you pointed out, like the fact that this is intermittent and kind of improves on its own, and then we kind of later learned alleviated with nitrates. I think if it ends up being vasospastic angina, that intermittent nature of this is something that I think is unique to this. But maybe if it's not vasospastic angina, other people mentioned this in the chat, but maybe if it's a non-cardiac thing, is there like an esophageal spasm? I think, I know Mario said there weren't any associations with, postprandial, prandial, and maybe if it was an esophageal spasm, there would be more related to meals. So maybe that's less likely, but I think it could still be some non-cardiac etiologies too, but probably vasospastic angina highest.
Beautiful discussion. And you guys really identified the key piece of the illness script for vasospastic angina that we need is documentation by EKG changes of impaired perfusion during a pain episode. So we've had a few normal ECGs other than the left bundle that was old, but Mario can clarify with us shortly, were any of those done and available during the actual pain episodes, or were they always captured after they were over? The kind of main criteria for vasospastic angina are, as we identified, response to nitro, the vasodilator, ECG changes during episodes, but usually without any prolonged vasospasm leading to actual ischemia with troponin elevations. And then to clinch the diagnosis, you want to prove under the right pathophysiologic conditions that the arteries do spasm. And so you can actually do coronary angiogram with vasospastic testing with chemicals. Often acetylcholine is used to see, does that vessel actually, when provoked, clamp down and then open up again when a vasodilator is given intravascularly. So a really important data point is, as everyone has mentioned in the discussion in the chat, is were there ever ECG changes during the pain episodes themselves? If not, it really does make us look towards perhaps this esophageal category as more likely without the actual changes in the perfusion on ECG. So Mario's super, super curious to see what direction she went in.
So yeah, in terms of the EKGs, she got an EKG every time she had a chest pain episode. So after a week, she had around 30 EKGs performed.
Poor lady.
They were all normal, so no ischemic changes were noted on the EKGs. So at this point, vasospastic angina was also entertained, but a different test was performed. GI was consulted, and they suggested to perform the esophageal manometry exam. And she had that exam, and what was noted was that on around 25 to 30% of all the swallows, she had a DCI, that's like a measurement for contraction, that was over 8,000 millimeters per mercury per second per centimeter. Yeah, you want to stop there? That's the last aliquot.
Wow. Amazing case, Mario. I love the iterative presentations. I mean, that's very much what diagnosis is in real life. We think we got it, but then they come back and we have to keep working at it. Maybe Reshma and Maddie, we could each share a quick reflection and then hear some kind of reflections from Mario before we do teaching points.
Yeah, it's such an amazing case. I really like the flow of the case more than anything else. How much we thought it was so serious, and then we even took the patient for cath, and then the patient coming back in again, the similar symptoms. We were thinking about pulmonary embolism and all different things, and then it's a totally different diagnosis. It's just a GI-related esophageal spasm. I was thinking like how important it is to have our minds open at all time, to not like miss out on anything, not easily think it's not that. I know this is not that. So it's important not to just fall in love with the diagnosis. It's important to evaluate every single symptom as its own. So that is a very big reflection and take home for me.
Yeah, I just want to say, Mario, this was a brilliant presentation and just so much fun to go through. I feel like it was just really fun. I mean, also to discuss with Reshma and Steph, but I think this was just such a great learning case. I mean, I think if someone comes in with chest pain, I think you still need to do that same workup to rule out the morbid causes. But I think something that I'm reflecting on is like the intermittent nature of the chest pain and how that was kind of a clue of if it's intermittent, like something is likely spasming or just like intermittently kind of clogging off. So the intermittent nature of this is something that I think I'll probably reflect on. And then just the importance of, you know, when you are doing an EKG and other tests, that's just one snapshot in time, and how, especially if someone has these intermittent symptoms, trying to get the test at the same time, which is probably hard logistically, but is probably really helpful, like diagnostically.
Which was exactly my reflection. The value of an ECG is very dependent on its timing of when it's captured. And so it sounds like Mario and the team were extremely diligent about getting them in the moment of pain. And that was very, very helpful negative tests to lead towards the eventual diagnosis. Awesome, Mario. What other points would you like to add before we do a wrap up with Noah?
Yeah, I think, Maddie mentioned on one of the last talk was esophageal spasm, and she nailed it. So the great discussion from you all three. It was an interesting case to present, but a very frustrating case to work through. For me, the teaching point, what I learned from this case is that besides vasospastic angina, especially if EKGs are normal with each pain episode, a differential diagnosis of intermittent chest pain that alleviates with nitrates is you should think on esophageal spasm. So the final diagnosis in this case was a hypercontractile esophagus, or also called jackhammer esophagus. It's one of the subtypes of esophageal motility disorders, and the diagnosis is based on the esophageal manometry findings. So I really like the work through of chest pain, really now the morbid causes. And after a brief literature review, I found that we usually think of esophageal spasms with pain associated with some type of something related to eating. That's usually what I have in my mind. But chest pain from esophageal disorders, from motility disorders, can be provoked by swallowing, provoked by postural changes. It can also be alleviated by antacids. It usually has an inconsistent relationship to exercise. It's usually substernal and usually does not radiate, but as in this case, it can also radiate. And it can also cause frequent episodes of spontaneous pain. So this was an atypical presentation of a fairly, at least in terms of the chest pain syndrome, not one of the most common cases. And yeah, the patient did well. She was after the diagnosis, she was discharged with some. She was discharged and she's done good. So yeah, thank you for the great discussion. I think it was a learning experience for us all. Thanks.
Thank you. Yeah, good reminder that while we're not eating all day, we are swallowing all day, right? Saliva. So the fact that it was occurring outside of meals, right, makes a lot of sense in retrospect. Awesome, fantastic job, Reshma and Madi. Just really great discussion and working through some kind of serious diagnoses and eventually getting into the right direction. Noah, take us home with some teaching point summary.
Hey everyone. So today we went on a diagnostic roller coaster. We first started with an 83-year-old female with intermittent chest pain. We started talking about our approach to chest pain. It's has a broad differential diagnosis, and it's very important to rule out emergent causes. So the framework 4+2+2 help us guide on those initial steps. It's important to use epidemiological data to guide thinking beyond that, and also the anatomical approach can be very useful. There's like an amazing schema in the CP Solver's website. I suggest you all check it out. We also talked about if there is suspicion for cardiac ischemia, the most diagnostic value is obtained through objective findings of EKG and troponin levels. The history, although we are taught that it's very important if it radiates or not, but the likelihood ratios aren't that great. We briefly mentioned the episodic nature that could give us clue, and in the end, it proved us right. After that, we got a very benign physical exam and some labs. The D-dimer kind of threw us off curve. We were led into thinking maybe a PE is a possibility, even though all the pieces didn't fit. The patient had an intermittent pain syndrome and the elevated D-dimer, but that's it. She didn't have tachypnea. She didn't have hypoxemia. Her heart rate was normal. And she didn't have a PE, so it confirmed our suspicions. EKG findings, we had a left bundle branch block. It's very important to compare to baseline. We saw that this bundle branch block was an old block, so we reassured that this was not an acute event. After that, the patient went to the cath scan, went to the cath lab, got a stent, and we thought we had the diagnosis. So she probably had like myocardial ischemia causing this intermittent chest pain. But then we're surprised with the recurrence of symptoms. And we talked about how this can be either one of those two things, something else other than the heart causing the symptoms, or a complication of the procedure. The second time meeting this patient, it's very important to revisit the history, see the vitals, and rule out complications of the procedure. Seeing the patient, we were reassured that the stent was working fine, and the history didn't give us many other clues. Then we went back into the episodic nature, and with the help of the nitrate responsiveness, we started questioning the first diagnosis. Vasospastic angina crossed our minds. It's important to remember the criteria. And although this patient had the nitrate responsive angina, she didn't have EKG changes during the episodes. And some final reflections, don't fall in love with the diagnosis. So we thought it was the heart, but it turned out to be a completely different system. I love this teaching point. The intermittent nature is key. Think about how the disease progresses. If there's a mass compressing, you probably won't see intermittent symptoms. You see a progressive symptom. So intermittent was key to diagnose this patient. The timing of the EKG is very important. So the conditions in which the EKG is obtained. And the intermittent chest pain responsive to nitrate, think of vasospastic angina, but also think of esophageal spasms. And that's all I have for today.
Awesome, Noah. What a great summary. Thanks again, Mario, for presenting, and Maddie and Reshma for discussing, and everyone else for your participation. Always such a highlight of these Wednesdays. Look forward to seeing you all next time. Have a great day.